thanks so much to everybody for coming out today. We appreciate it. Thank you, Kathy, for the really nice introduction. Wanted to just take a little bit of time this morning to tell you guys about the different types of Chiari malformations, because it can be very confusing. And it's even to someone, when I was learning this stuff in medical school and residency, it was hard to keep straight sometimes. So we'll go through each thing and what the important features are. And then I wanted to focus a little bit more on what's called Chiari 1.5, or sometimes people call that a complex Chiari malformation. Okay. Objectives for today, I have no disclosures. So Chiari has a pretty long history in the medical field. I think it was actually first probably diagnosed a little bit before this, but Dr. Hans Chiari was the first person to name it and categorize it in 1891. And the basic issue with any type of Chiari malformation is that there's an impairment of CSF flow around the craniovertebral junction, or the junction between the head and the neck. And there's all kinds of different treatment philosophies and ways that you can take care of people with this. You'll also hear about what are called acquired Chiaris that may be due to a brain tumor or hydrocephalus or idiopathic intracranial hypertension. That's actually a completely separate topic from what we're going to talk about today. So just to start off, Chiari Zero, I'm doing it first, but it's probably one of the most recently described forms of Chiari. It's first described at the University of Wisconsin in 1998. It's essentially where you don't have any abnormalities of the cerebellar tonsils, but you do have an outlet obstruction of the fourth ventricle. So what that means is, here's our fourth ventricle. CSF can't flow out of the fourth ventricle and down around the spinal cord. And for it to be called a Chiari Zero malformation, you have to have a spinal cord syrinx, which is a collection of CSF within the spinal cord, which you can just barely appreciate here. So Chiari Zero, syrinx, and fourth ventricular outlet obstruction. Treatment is, if you're going to treat that, it's the same as a Chiari I or other type of Chiari. By far the most common type is a Chiari I. This is when here's our cerebellum. The tonsils, which are the very lowest part of the cerebellum, are hanging down below the base of the skull. So if you draw a line like this from the occipital bone to the clivus, that's the base of the skull, and you shouldn't really have much cerebellum below that. So when you do, or when you have more than 5 millimeters of cerebellar tonsils below it, that's a Chiari I malformation. Commonly associated with a syrinx, probably 25-30% of people have a syrinx with this. And the symptoms are posterior headaches, neck pain. You can have swallowing issues. If you have a significant syrinx, you can have symptoms of myelopathy, which is fine motor issues, numbness, tingling, trouble with coordination of your arms and legs, back pain. It can induce scoliosis in children as well. Talk a little bit more about indications for surgery, but essentially you have to have the appropriate radiographic finding, and you have to have the right symptoms that we can refer to that. Okay, so one of the common things, probably the most common reason I see somebody with a Chiari is that they have headaches, maybe they have migraines, and they get an MRI from their primary care, their neurologist, and it shows a little bit of a Chiari. And then when I talk to them about the Chiari and how we're going to manage them, I really want to know, are we having symptoms that are directly referable to Chiari, or is it some other type of headache, whether it's migraines, tension headaches, cluster headaches, those types of things. And by far, the most common issue is for it to be some other kind of headache and not necessarily from the Chiari. This is just another example. This is a sagittal image. Here's the cerebellum. It's really significant Chiari. Here's the bottom of the skull. Okay. Surgery involves removing the bone and opening the dura. And then here's just what it can look like a few months later with the tonsils reduced, that bone gone. Here's the outline of the dura. Okay. And you'll note that all the compression that was right here at the craniovertebral junction is gone. Here's an example of a little girl who came to me with scoliosis. And in the orthopedic surgeons who are mostly seeing patients with scoliosis, they're getting MRIs on just about every kid. The reason for that is they're looking for either a Chiari malformation or a tethered spinal cord, because both of those things can induce scoliosis in children. In this case, she had a Chiari and she had this really significant hollow spinal cord syrinx. You can see how the spinal cord is dilated and filled with CSF being bright on this image. And here's the rest of her back, so literally all the way down to the bottom of the spinal cord. So the treatment for that is, remove the bone, do a duroplasty, decompress the Chiari. This was her about 3 months later, showing no compression at the craniovertebral junction, significant improvement in her syrinx. In a situation like this, I wouldn't ever expect that syrinx to go away completely, just given how severe it was up front. But if you can make it better like that, that's the goal. Some people think that there could be a common developmental mechanism between Chiari I and Chiari Zero, that being a congenitally small posterior fossa. So the posterior fossa, which is, go back a couple slides here to show you better. Posterior fossa is this space in the brain that's below a dural layer called the tentorium within the skull and behind the brainstem. So really this area where the cerebellum sits, that's the posterior fossa. It's just what we call that space in the skull. And the thought is maybe that people with these conditions just have a smaller one than normal, and that's kind of what predisposes people to it. So I wanted to focus a little bit on Chiari 1.5 because it's not nearly as common, but it can be a little bit more challenging to deal with and to recognize. So I wanted to go through that just so you guys know what that is. So as the name would suggest, it's sort of a combination of a Chiari I and a Chiari II, kind of halfway in between. We'll talk about Chiari II in a minute, but in general, in Chiari II, that's associated with spina bifida, almost universally. And part of the features of that is you have kind of a sagging or displacement downward of the brainstem and the fourth ventricle, as well as the cerebellum. Chiari I is probably about 15% of cases. It's not associated with any neural tube defects like spina bifida. We look here on this MRI scan of this patient with a Chiari 1.5 malformation. This is the brainstem. Right here, this is the midbrain, the pons, the medulla. Here's the cerebellum. If we draw our imaginary line here, here's about the bottom of the skull, and you can see the medulla is way below the bottom of the skull, and the tonsils are way down there as well. The pons is also sitting much closer to the skull base than it typically does. Okay. One of the key things to look for is the position of the obex, which is about right here in this patient. Normally, that's about a centimeter or so above the bottom of the skull, and Chiari 1.5, on average, it's about that far below the skull. Okay, so that's one of the things that we always look for. And then you have thinning of the medulla, just because it's getting kind of squeezed down through the foramen magnum at the bottom of the skull. This is just an anatomical drawing of the brainstem. So if you're looking, say you're looking at the brainstem from the back, this is the cerebellum. The cerebellum kind of folds around the brainstem. In this picture, it's been removed. Here's the medulla, here's the floor, the fourth ventricle, and the midbrain. The obex kind of sits right here. And the obex is really the opening to the central canal, which is the part of the spinal cord that contains some spinal fluid, and that's what becomes really dilated in patients with syrinx. Okay, so the thought is that if this is getting occluded, that could be what contributes to a syrinx formation. This is a cadaver model kind of showing the same thing there, okay, where the obex is. For the fourth ventricle, cerebellum removed on each side, midbrain above there. So there are some other features that are really important to look for on any patient who you're seeing with Chiari to pick out whether it's a Chiari 1.5 or not. And they have to do with the structure of the skull base and whether there's instability in the junction between the skull and the neck. and whether there's any other congenital bony malformations of the skull in that area too. So one of the things that we always look for is what's called a retroflexed odontoid. The odontoid is another name for the C2 bone. C2 is like a peg on which C1 sits, which is like a ring. So if you think about when you rotate your head, most of that motion is coming from that ring on the peg of C2, okay? So here's the dens in this part. And in Chiari 1.5, that odontoid can be really pushed back into the brainstem. We call that a retroflex dens. And that can contribute to symptoms, but it can also be a marker of instability of the neck. Okay, so just always something really important. And there's a nice measurement that they developed at University of Alabama, where you can, they call it the PBC2 line, where you can do a measurement and sort of gauge what your risk of that is for a particular patient. Patients can have some degree of basilar invagination. That's when the C2 bone is riding up inside the skull, just putting pressure on the brainstem. You can have something called occipitalization of the atlas, which you can't see in this picture, but that's essentially where the C1 bone is fused to the base of the skull. You can have an abnormal clival cervical angle. So this is the clivus here. So the angle between the clivus and the C2, that should really be about 125 degrees or more. And if you have a smaller, more acute angle than that, it can lead to issues with stability and ventral brainstem compression. And then obviously you can have the usual things that you have with Chiari I, which is the syrinx, or it can be associated with scoliosis. Okay. So here's a picture of a patient with a Chiari 1.5. Some of the features here you can see. Here's the pons right here. Here's the base of the skull right here. The medulla is way down there. The arrow points to where the obex is, so well below the bottom of the skull. You can also see this dens is sort of pushing back into the medulla somewhat, and they have a relatively acute clival cervical angle, and they have a large syrinx associated with that. Okay, so it kind of gets all the features in one picture there, which is nice. Here's just a graphical representation of that. So like I was mentioning, the clival cervical angle is the angle between the back of the odontoid process and the back of the clivus. If that's less than 125 degrees, then you need to think about Chiari 1.5. This is a picture of what basilar invagination looks like. So this dotted line is from the basion to the epistheon, essentially the line that forms the bottom of the skull, and you can see the C2 process is hanging above that. This is a graphical representation of the PBC2 line that I was mentioning. So you draw a line from the bottom of the clivus to the back of C2, and then you measure the distance from that line to the tip of the odontoid. And if that's more than 9 millimeters, then they're higher risk for being unstable and possibly needing a fusion. If it's less than that, then you can feel good that they will not need that. So how do complex Chiaris present? Well, really in all the same ways that Chiari I can, with the added part that people can have symptoms referable to the brainstem more often. So bulbomyopathic is kind of a mouthful, but essentially what that means is symptoms related to brainstem compression, so swallowing problems, central sleep apnea, myelopathy, which is a term we use for chronic compression of the brainstem or spinal cord that results in fine motor problems, coordination problems, numbness, tingling at its worst, actual weakness. Okay. And then young kids, they can get something called oral motor apraxia, which is where they can have a difficult time coordinating their soft palate, tongue, and jaw to eat and produce speech and things like that. So what's the evaluation? We kind of talked about it, but MRI is the most important thing, and you look for all of those features that we just talked about. And then how do you make a decision about what to do? Well, fortunately, it really comes down to the same kind of decision-making process you'd use for a Chiari I. So, how bad does it look? How bad are their symptoms? Is it altering kids' lifestyle, are their symptoms limiting how they can play with their friends? They have to stop playing before they want to. Are they missing school because of symptoms related to this, et cetera, et cetera. So that part is essentially the same. Most of the time we're picking these up incidentally. So as I mentioned, child has some other problem. They have migraine headaches, or they have some other type of headache, or they have scoliosis, and we find it that way. But when we do have a child and we're going to decide that they do need surgery, there's a couple of options. So kind of the standard option is a posterior fossa decompression, which is removing the back part of the occipital bone that overlies the cerebellum and upper and lower brainstem, and then doing a C1 laminectomy, which is removing the very back part of the ring of C1 to provide extra space. You then have the additional option of doing bone only, or removing the bone and then opening the dura, as I had showed in one of my earlier cases. And then if it's Chiari I, you have to decide whether you think they need a fusion or not. So you look for all those features that we talked about. You probably get flexion extension x-rays. That's where you have kids bend their head all the way forward and then all the way back. Take x-rays while they're doing that, and you see how the bones of the skull move together. And if there's more movement than there should be, we call that instability, and that means they probably need to have a fusion in addition to their Chiari. Odontoidectomy is something that's fairly rare, but in those Chiari 1.5 cases, if there's really severe retroflexion of the dens and it's really pushing into the medulla, you might have to go through the mouth and remove that bone. Okay? Yeah.
Can I ask a question right there? What would be the symptoms after you have the decompression and the fusion? What would be the symptoms that would imply that you might need the odontoidectomy?
So if you had, good question. So if you had, the more common scenario would be if you just got like a regular Chiari surgery where they did the decompression but they didn't do any fusion. And if it was a 1.5, then you just have symptoms of brainstem compression. So you could have worsening myelopathy, weakness, numbness, swallowing issues, things like that. Yeah. The group out of Utah came up with a nice kind of flow chart that you can sort of look at and think about how you're going to make decisions about how to care for these people. Of course, every patient is individual and special, but this is kind of a general outline. So up here, simple Chiari, the standard treatment, suboccipital decompression. The duroplasty is what we talked about, opening the dura or not, and then C1 laminectomy. Okay, so that's the most simple way. If it's complex, you look at the PBC2 line. If it's over 9 and they have an acute angle and they're having symptoms, most of their patients ended up getting this Chiari surgery plus a fusion. If they had a more normal cervical angle, depending on whether they had symptoms or not, whether they needed a fusion. If they didn't have those bulbar myelopathic symptoms, they got the standard treatment, okay? And then for this group, like we were just talking about, they're having persisting symptoms after that, that's when you talk about doing the odontoidectomy. Okay, so I hope that was somewhat insightful about one of the types of Chiari that maybe people don't think about all the time. So Chiari II, this is Arnold Chiari II. This is associated with neural 2 defects, myomeningocele spina bifida. It has a bunch of associations with it. Small posterior fossa, couple files where bones in the spine are congenitally fused together, hydrocephalus, and large masseter media is an adhesion between the thalami and the brain. And these are all just kind of markers for it. This is a picture of it. So you can see, sort of similar to the Chiari 1.5, you have this really downwardly shifted brainstem, downwardly shifted fourth ventricle. Okay, and compressions all come from the brainstem. So it's apnea, breathing problems, swallowing problems, vocal cord problems, syrinx. Chiari III is a little bit different. This is extremely rare. This is really more like an encephalocele. An encephalocele is when you have a portion of the brain that forms outside of the skull through a skull defect. Because that's really what this is. This is where you have a skull defect here. This is cerebellum coming out of the brain, out of the skull, and then you have a big set pouch of CSF here. So you typically will see the child with an extra kind of like mass on the back of the head. So called the Chiari III, really not related to what we've been talking about so far. And then Chiari IV is a condition, is extremely rare too. You have no cerebellum or a very small cerebellum. And so again, really different from what we've been talking about today, and there's really no role for neurosurgery in that particular condition. A lot of people ask about, what kind of sports can my kid play if they have a significant Chiari, and if you go to 10 different pediatric neurosurgeons, you might get 6 or 7 different answers on that. The concern that there is that because you have less room at the craniovertebral junction, if you were to have a whiplash injury or significant flexion extension injury of the neck, you could get a spinal cord injury. Okay, because normally at the craniovertebral junction, your spinal cord is there, and there's lots of extra space and spinal fluid around it. But with Chiari, that space is filled by cerebellum, so there's not as much room. There's never been any great data showing that, okay? There are certainly case reports in the literature that describe sudden quadriparesis or paralysis after an injury of people with Chiari, but when people have tried to look at this in a more formal way, that there hadn't really been able to find much of an association. So where do I come down on this? Well, things that are considered contact sports, especially like football, lacrosse, ice hockey, I really recommend my patients try to stay away from those if at all possible. I think things like basketball and soccer, especially now that kids are hitting the ball less and less, it's really less of an issue, okay? And then all these other sports are okay, limited contact or non-contact. So, they have ultimate frisbee on here, ultimate frisbee skiing. So maybe, if you like playing ultimate frisbee, maybe play frisbee golf. I don't know. It's just that's actually pretty fun too. Anyway, so like I was mentioning, a wide range of data on that, and what's the real definition of safe? Nobody really knows what that is, and it's really a judgment call. So, okay, well, I wanted to give you guys a nice update on what Chiaris are, Chiari 1.5. If you have any questions, I'd be happy to answer them. Yes? Yeah.
The 1.5.
Yeah.
Have you ever seen literature stating that can be an acquired Chiari?
Yes.
The reason I ask is I believe that's exactly what my daughter had after a high jump fall without a mat.
Okay.
And all of those, every single, she clicked off every single thing you mentioned, and she's already had the fusion, and she still has symptoms.
Yeah.
And her odontoid is still pressing into the spinal cord, into the medulla, and I just was wondering if that might be the next step that I should be taking.
Yeah. I know that people can develop that over time. So there are examples of people who have like a somewhat normal MRI, and then several years later, now they have a Chiari 1.5. I'm not aware of any data about an accident or a traumatic event causing that. So not to say that didn't occur, but I'm not aware of any information about that.
Thanks.
Yeah. Yeah.
So, on the contact sports,
Yeah.
you said soccer is okay, but if a big thing in soccer now is a lot of headers, you probably would not recommend doing that.
Yeah, so what I talk to my families about are the headers are really the danger. And these days, more and more leagues are limiting headers and things, so it's becoming a little bit less of an issue. But I have the conversation with them about that and what the theoretical risk is. And I'm not going to sit there and say that they can't let their kid play soccer, because it's a really great sport and a common thing that kids do, but I want them to at least have the information.
And I think the new law, at least in Illinois, is U12 and under, no headers. But still our high school kids and pro and college are able to still head the ball, but the younger ones.
My son continued to play travel soccer after Chiari decompression, but he never had
thank you so much. Thanks to Kathy for organizing and everybody who came out. Appreciate it. Yeah, I knew it. Thank you.